Contraception or birth control is used to prevent unplanned pregnancies. The efficacy of a contraceptive method can be seen in this table of perfect and typical use. Note that there is a big difference between perfect and typical use in those methods that are dependent on user compliance. This is in contrast to those that are independent of the user. Contraception methods can be separated into two categories, hormonal or non-hormonal. In this video, we will focus on the hormonal methods. There are two types of hormonal contraceptive methods that women can choose from: combined hormonal methods and progestogen-only methods. Under the combined hormonal contraceptive method, various combinations of synthetic estrogen and progestogen hormones are released into the female body. The primary mechanism of action is prevention of ovulation by suppression of luteinizing hormone, LH, and follicle-stimulating hormone, FSH. Effects on cervical mucus, endometrium, and tubal motility also contribute to its efficacy. Combined oral contraceptive or COC pills are daily oral contraceptives that contain an estrogen paired with different formulations of progestogens. They come in pill packets of 21 or 28 pills. The pill should be started on day 1 to 5 of menses and works immediately. The 21 pill packets are to be taken for 21 days with 1 week pill-free break. The 28 pill packets contain additional placebo pills so that the woman can continue taking throughout without break. This has been shown to improve compliance. The COC pill method is highly effective if taken consistently and correctly. There is a 0.3% failure rate with perfect use and 9% in typical use, with majority of failures due to non-compliance. Enzyme-inducing drugs listed here and the herbal preparation St. John's wort may reduce the efficacy of combined hormonal contraception. Usually, a method where there is no drug-to-drug interaction is better. These include the progesterone injection and the intrauterine methods. Combined hormonal contraceptives also provide other benefits like these. The COC pill is not ideal for women who are forgetful about taking daily medications. Minor side effects of using hormonal contraceptive methods such as COC pills include nausea, breast tenderness, and headaches. These are usually temporary. COC pills are associated with a small increased risk of myocardial infarction, ischemic stroke, and VTE. Some CHC formulations are associated with a greater risk of venothromboembolism, VTE, than others, and this relates to estrogen dose and type of progestogen. Current use is associated with a small increased risk of breast and cervical cancer that reduces over time. The following are absolute and relative contraindications to the use of combined hormonal contraceptives. Detailed history taking is therefore mandatory to assess a woman's medical eligibility for a contraception method. The transdermal combined E plus P patch or EVRA patch is another combined hormonal contraceptive method. A single EVRA patch contains ethinyl estradiol and the progestogen norelgestromin. It has a failure rate of 0.3% with perfect use and 9% with typical use. On day 1 to 5 of a woman's menstrual cycle, the patch is applied to clean, dry skin on the upper outer arm, buttocks, abdomen or thigh, and changed on a weekly basis on the patch change day for 3 weeks. The 4th week is patch-free to allow a withdrawal bleed. The cycle is then repeated. The patch is simple and convenient to use and only requires weekly attention, hence compliance may be easier. Direct-to-skin administration helps if the woman has medical conditions which interfere with its digestion and absorption. The Evra patch is not suitable for women who are forgetful about changing it regularly. It may fall off due to sweat. Side effects are similar to those of combined oral contraception, though breakthrough bleeding is less. A minority of women are allergic to the adhesive. Most of these side effects tend to reduce or go away after 2 or 3 months. Other forms of the combined estrogen and progestogen contraception methods also exist in the form of the E+P vaginal ring and E+P injections. These methods have similar benefits, risks and side effects as the other combined E+P methods we've discussed. A ring is inserted into the vagina for 21 days. After removal for 7 days to induce a withdrawal bleed, a new ring is inserted. The other group of hormonal contraceptive methods are the progestogen-only methods, which include progestogen-only pills, progestogen injections, subdermal implants, and the intrauterine system. Progestogen-only pills, or POPs, contain very low doses of progestogen. They are also called mini pills. Examples include Microner and Cerazette. POPs work to reduce sperm viability and penetration by thickening mucus produced by the cervix. It also inhibits ovulation in up to 60% of cycles. DSG works by inhibiting ovulation in 97% of cycles. POPs need to be taken orally at the same time each day, continuously without a break. DSG POPs are more flexible but need to be taken within 12 hours. It has a 0.3% failure rate when used perfectly, but increases to 9% failure rate with typical use. POPs does not affect milk production and are suitable for women who are breastfeeding. They are an option for those who cannot use COCs. Fertility reversal is immediate. There are no significant metabolic effects, with lipid levels, carbohydrate metabolism, and coagulation factors unaffected. A backup method is needed for the next 48 hours if POPs are taken more than 3 hours late. It is also not suitable for patients on liver enzyme-inducing medications, example, some anti-epileptics. POPs can cause frequent, prolonged and irregular bleeding or extended amenorrhea. Other side effects include headaches, mood changes, nausea and breast tenderness, which usually reduced after 3 months. The following are absolute and relative contraindications to the use of progestogen-only contraceptives. Detailed history taking is mandatory to assess a woman's medical eligibility for this contraception method. Injectable progestogens are depot injections of medroxyprogesterone acetate, DMPA, commonly used in Singapore, and norethisterone enanthate, NET-EN, may be available in other institutions and countries. The DMPA dosage of 150 mg every 12 weeks are administered as deep intramuscular injections in the deltoid or gluteus muscle. Pregnancy rate associated with injectable DMPA is at 0.2% with perfect use and 6% with typical use. Depo-Provera follow a 3-monthly dosing schedule and is convenient for women who cannot keep up with daily or weekly administrations and for breastfeeding women and those on liver enzyme-inducing drugs. It works immediately when started on day 1 to 5 of menses. It can also be administered immediately postpartum or after first or second trimester abortions. No increased risk of VTE associated with this method of contraception, but can cause fertility return to be delayed by up to 9 to 12 months from the last injection. Altered bleeding patterns such as amenorrhea, prolonged, spotting or infrequent menses are common. Reversible loss of bone mineral density has also been observed, particularly with over a year's usage. Care should be taken in recommending DMPA to adolescents and women older than 45 years. Use is associated with weight gain, particularly in women under 18 years of age with a BMI more than 30. Those who gain more than 5% of weight in the first 6 months of use are likely to experience continued weight gain. Injection site reactions can occur, including pain and bruising. Side effects such as acne, decreased libido, mood swings, headache, and hot flushes have been reported. The current generation of progestogen implant is the Implanon NXT. The Implanon NXT is a single-rod subdermal contraceptive implant that is soft, flexible, and non-biodegradable. Barium is present in the rod to aid location of non-palpable devices. The implant contains etonogestrel 68 mg on an ethylene vinyl acetate EVA copolymer core and provides contraception for 3 years. The implant comes in a pre-loaded applicator for easy insertion. The procedure is performed by a trained healthcare professional under local anesthesia. It has high efficacy with a 0.05% failure rate for both perfect use and typical use. This method of contraception gives long-term reversible contraception but also allows rapid return of fertility when removed. Proper counseling before the use of this method is essential, as it may cause irregular bleeding patterns and amenorrhea in 40% and 20% of women, respectively. The device is non-biodegradable and must be removed by a trained healthcare professional. Other side effects include headache, breast tenderness, water retention, and weight gain. Contraindications are similar to those of other progestogen-only methods. There can also be complications from the insertion procedure that include bruising and discomfort after insertion, infections, neurovascular damage, or misplacement due to inaccurate or deep insertion. Implants that are not palpable should not be removed until the device is located and sighted by ultrasound. Another progestogen-only method is the levonorgestrel intrauterine system, LNG-RUS. The LNG-RUS contains 52 mg of levonorgestrel, which is released steadily at a rate of 20 mcg per day. It is effective for up to 5 years. It has a 0.2% failure rate with perfect and typical use. The LNG-RUS has minimal systematic hormonal effects and is an effective treatment of idiopathic menorrhagia, iron deficiency anemia, and dysmenorrhea. It also suppresses symptoms of endometriosis and is an effective option in treatment of endometrial hyperplasia. It provides the progesterone component of hormone replacement and is safe and effective for adolescents, nulliparous, and older women with rapid fertility return. The LNG-RUS shares the same disadvantage and procedure complications as the copper IUD, but includes additional side effects from progesterone-only methods such as irregular bleeding patterns, amenorrhea, and mood changes. The insertion process can be uncomfortable and should be performed by a trained health professional. The following absolute and relative contraindications to the use of hormonal RUS must be ruled out before recommending to the woman to adopt this form of contraceptive method. A woman's choice of contraception method can be affected by a combination of extrinsic and intrinsic factors. Extrinsic factors include age, future fertility plans, medical, family medical and drug history, influence of husband or partner or peers or friends or family, and socio-economic factors. Intrinsic factors are factors linked to the contraception method, such as its efficacy, mode of action, delivery, duration of effect, reversibility, side effects, risks, non-contraceptive benefits, and cost. Emergency contraception pills, ECPs, are used to prevent pregnancy following unprotected sexual intercourse and are sometimes called morning-after pills or postcoital contraceptives. ECPs work by preventing or delaying ovulation. There are 3 methods currently offered for emergency contraceptions. 2 are oral, progesterone only, effective up to 72 hours from the last sexual act, and Ella-1 allopurinol acetate, UPA, effective up to 5 days from the last sexual act. The third EC method is intrauterine copper device, IUCD, the most efficacious method for emergency contraception up to 5 days from last sexual act or up to 5 days after predicted ovulation, usually day 19 of a 28-day cycle. These methods are dependent on the date of unprotected sex and the date of her last menstrual period. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.